I'd like to welcome you all to our annual general meeting for 2023-24. For those of you that don't know me and haven't had a chance to say hello to this evening, I'm Pauline Tagg, I'm the acting chairman of the ICB, and I'm delighted to see so many of you here this evening. This is the agenda for today's meeting. I'm not going to say a lot. I'm going to be handing over to our Chief Executive, Caroline, the Finance Director or the Chief Finance Officer, Robert, and Chief Operating Officer, Rachna, who are going to do most of the talking today. But I am going to keep them strictly to time, because the important part of this evening is your opportunity to ask us questions and for us to answer as much as we can in this evening's session. It would be remiss of me at this point not to make mention of David Sislin, our previous chairman, who actually was the chairman through this year that we're going to be talking about. And he actually left the trust on the 31st of March 2024. And David was really instrumental in setting up and establishing the ICB, and we owe him a great debt of thanks for that, and wish him well in his future. We also, during the year, said goodbye to our Chief Executive, Mr. Andy Williams, who many of you will know and remember, who again, with David, was instrumental in getting the ICB up and running and on its feet. And again, we wish Andy the best of luck in his future. We welcomed Caroline, the Chief Executive, in, I think it was November, she started in, November. She started and actually saw us through the winter period, which was very challenging. And the Darcy review, again, I need to make mention of that because it's recently been published. Everybody's talking about it. I've been in the NHS over 50 years and there's nothing in it I didn't really know, if I'm being honest. And I'm not sure the NHS is broken. I don't like to hear people say that. I know we're struggling. I know we've got a lot to do to get better, but I'm convinced that with the passion, the love and the commitment of the people that work in the NHS, we will fix it. It'll take us a long time, but we love a crisis in the NHS and we always rise to the challenge, and I'm sure we'll do that this time. So with those few words, I'm delighted to hand over to Caroline, the Chief Executive.
Thank you, Pauline, and may I add my thanks to people coming out on such a rainy night. The rain, and lightning, I think, or it's the flash of the camera, I'm not sure. I'm Caroline, I'm the Chief Exec, been in post to say since November, took over from Andy. Andy left a really, really good legacy, I think, in terms of moving us from CCGs into the ICB and setting us along the path that the successes that Ratch is going to talk us through has really started with Andy, and I was really proud to take over from him. But I want to introduce us to the ICB because there may be people in the room that still don't know what we are. We were established back in July 2022. So this is only our second annual general meeting as an integrated care board. And I think it's probably fair to say that commissioning organisations, you might feel that they come and go and that what do we do? But the ICB, I think for me, is a real opportunity to work differently in the system and bring partners together to deliver on the needs of the population in a way that we've never been able to do before. In the past, there was a lot of competition in the NHS. We weren't really set up in a way to engage, and the ICB does give us that opportunity to do so. So we replaced clinical commissioning groups, and we serve a population of 1.1 million. And I think it's good to see the fact that we've got such a diverse population, because it enables us to really think about the challenges for health equity. We're not just serving a similar population. We've got real challenges and real difference in our community, and I think that makes it a really exciting and vibrant place to work. It's a statutory organisation working with our partners, and our responsibility is around managing the resources for the NHS. It sounds very very boring if you just look at it like that. But ensuring that we've got the right financial resource, human resource, working on delivering the needs of our population and coming together as a system to do that. And I think one of the exciting bits of the Integrated Care Board is our role as conveners of the system. And we often liken it to creating the conditions for success for delivering for the needs of our population. Who are we and what are we, how are we made up? Well, I think people understand the NHS, so they can think about our hospitals and our GP services, but the Integrated Care Board takes us beyond that. It takes us out into social care, it takes us out into the voluntary care sector, it really brings primary care to the fore. And these are some of our partners together working across the patch. University Hospitals of Leicester, we're obviously just across the road from one of their main sites, and it's great to see we've got colleagues in the room from them today. We've got not only the local authorities at Rutland, Leicester City and Leicestershire County, but the district councils as well. They play a really important part in terms of coming together around some of the work that we're doing on prevention. And we've got voluntary care sectors, some of our larger ones, such as Loros and Rainbows, but we've got lots of representation from the voluntary care sector in the room today, and we work with many organisations across the patch to come together to deliver on those needs. Is there anything else I want to say on that one? We've got a plan. You'd expect us to have a plan. One of the first things that we did as an Integrated Care Board was come together and think about the needs of the population and what that looks like. And so pulling together a 5-year plan was not only a requirement, but actually was the right thing to do for our population. And one of the things that the plan has enabled us to do is to align the plans across health and care. In the past, we'd have different plans and we'd hope they come together, but the Integrated Care Board infrastructure gives us the ability to pull those plans together so we're working towards the same aim. The way the plan is structured, it's around a life course approach. We're ensuring that people have got a good start in life, that they're kept well for as long as they can. When they start needing care, we make sure that we've got services to support them and try and maintain their well-being and independence for as long as we can. And then we're focusing on people dying well. But we've also looked at it from a pathway approach as well, and taking some of those pathways, including mental health, children's services, women's health. And putting all of that together, when you look at people's needs across a life course approach, but also the conditions that they have, makes it quite complex. And so what we've tried to do is pull all of that together in 13 approaches and 13 pledges to our public about how we're going to deliver on the needs and improve outcomes and reduce health inequality for our population. The pledges, you've got them in your slide pack. They're very difficult to read, but I would absolutely encourage you to read them because it sets out our commitment. One of the things that we're focusing on this year is kind of acknowledging that there's a lot to do, and if we put our energies into some of these pledges and think about how we might prioritise some of them to focus on the real challenges that our population are facing, then we might be able to achieve more. But we want to still deliver on all of these pledges. And I'm going to talk later about that future vision and what we're doing for this year. But those pledges are important to us, and I think that's what connects us with our local population, to ensure that we are delivering on the needs of the population and focusing on that. In order to make sure that it makes sense to our population, if you think about that 1.1 million, it's a very different population in Rutland to that in Leicester City. So we're trying to work at 3 different levels. And I'll start from bottom up because it makes more sense. I tend to do system, place and then neighbourhood. So as a system, LLR is our system, Leicester, Leicestershire and Rutland. And we want to deliver services at a system level where it makes sense to do so, to do that once. And these may be services that are very complex, that are very niche, and that hopefully people won't need very often, but it makes sense to do that. And our partners come together, we work really closely with our partners to think about where we might have similarities from the local authorities to come together at system. How might we do that? But then we take it down to place, and our places are our local authority footprints. And by having a real focus on delivering services and addressing the needs of the population at place, it allows us to focus on those nuances, those differences in our population. And although we're working towards the same aim, we can start to think about how we might need to do different things to reach out to different populations because of the place that they live in. Each of those places have got its own joint health and wellbeing strategy, and they come together to where we can do at system. And so they're building up towards that system opportunity. But care doesn't happen at place. It happens fairly irregularly at system. It sometimes happens at place. Where we really need care is at neighbourhood level. These are our local communities, our local populations. And so getting a service right for people across health and care at that neighbourhood level where people spend most of their time and spend most of their energies is critical for us. And so we've grouped our neighbourhoods around 30 to 50,000 populations that can really take the nuances, take the difference of populations and wrap, as it says there, wrap care around our most vulnerable patients because we can pinpoint them almost by street and by neighbourhood. So we've got some great examples of working with our partners. I'm not going to go through this, but I would absolutely encourage you to look at the ACE 100 website. It's part of our ICB website, but it demonstrates the things that we've been doing together. And Rachel's going to pull out some of these successes if I shut up. The other thing to do is to acknowledge that our annual report has been published. There are copies of it at the back if people want to take away a hard copy, but if not, it's available on our website and you can look at it online. So hopefully we're able to get it out to as many people who want to read it. I'm going to hand over to Robert now to go through the financial position. This is a formal part of our AGM, to go through the finance, and then after Robert, Rachel's going to take us through some of the exciting stuff we've done as a system.
You've got availability, you want both online but at the back to get hold of a copy of our annual report and accounts, and that gives a lot of detail around both the financial position and how we spend our money, but also of course gives us all of the activities and achievements that we've done over the last year, so it's worth a look. In terms of our financial review, I'll just do a very top-level overview. The key thing is that we receive, to the ICB, a number of allocations. So that's the funding that we have and allocate out to our partners. And that's our key providers, including obviously our primary care. We also have delegated services from the NHS England for the region, where we look after pharmacy, ophthalmology and dental services. And we know they're challenged, particularly the dental ones, but we do have funding to make sure that we can, assuming we can have efficient resources, get that spent properly for our population. That's what we want to do. And the bulk of our funding is spent on healthcare, of about 2 billion there. ICB running costs are limited. They've got to be kept to about 1% of our total allocation, and from that you can see it's a very small team that actually supports the entire system. That works out just over £2,055 a patient, and how that is actually spent or allocated, as you can see, the bulk of it goes into our acute environment. That does include planned care, so it's planned, elective, surgical care, cancer care, but also acute, so that's the emergency pathway as well. So you can see that's the biggest area of our allocation, followed by primary care, then we've got mental health and our community and continuing care services. The critical aspect, as you'll know from the DASI review, but actually what we're trying to do is to turn the dial, because the important thing is how do we actually manage to spend more money in care and prevention, early intervention, to look after our patients rather than them requiring treatment from an acute hospital. That's the key aspect that we're looking at, and hopefully over the next few years we'd hope to see the right-hand side shrink and more focus into that agenda of looking after people earlier helping them at home, caring closer to home, and actually getting the services and the diagnostics earlier so we can make sure they don't need acute services. That's the critical thing. How do we deliver value for money? Well, we do actually work with partners, so it's not about just, we do have contracts with lots of different partners, but we also have collaboratives, and Rach will talk through some of the ways that work, but we are set up to work with partners, both NHS, non-NHS, that includes the voluntary care sector, and that really is important to make sure that we can actually get good value, not just good value, but actually that we can get to patients where they need to be looked after from all areas. That's really important. What we also have to do, though, is the allocation that we receive isn't enough. So for the ICB itself, that's us as an organisation as opposed to the system, we have a financial improvement plan, and last year delivered efficiencies of 80 million to come up with the year-end number that we did. But what we also do is very much, as I said, is work with partners to improve pathways and make sure that we can reduce waiting times for those who need to be seen, wherever that is. Other key aspects, of course, is working with our clinical colleagues to make sure people have the right access to pharmacy and prescriptions, so it's cost-effective prescribing. And the last thing we do is making sure that we don't spend too much money in the management of that. So that's about us making sure we continue to review our management and administration of the ICB, and particularly where we can, then any savings laid from that are reinvested into the health sector as part of our position. In terms of financial measures, we actually have a break-even duty. We didn't achieve that last year. I think it was a very challenging year for us all, but we did agree an outturn with our regional colleagues and nationally, and we managed as an ICB to deliver an outturn plan of just under 15 million deficit, so 16 million deficit, sorry. So we did contain the outturn within what we said we would do. So there is something about meeting our expectations. As I said, we've also underspent on our management fees, and that was 4.2 million that we were able to put back into that number. We manage cash, so that's really important for us. There's only a certain amount of cash we can get, and the critical thing there is that we live within the amount we've got and only had a very small year-end balance. And the other thing that's really important is actually that we pay people. So, as you can see, we have successfully delivered on making sure that we pay our suppliers and other contracts 95% of the time, at least within the 30 days as required. Probably worthwhile just talking briefly about the challenges for this year. We are being delegated to provide additional funds for tertiary services in particular. So that relates to cancer, neonatal services, and renal services, for example. And that's a new delegation because it's hoped that obviously through the ICBs that we can work closer with partners and make sure our population gets those tertiary services they require and need. So that's a really important thing going forward. However, we are still facing significant financial challenges, whether that's partly due to the actually the demand on our services, particularly across the entire acute sector, whether that's access to GPs or whether that's access to other health services and the emergency services. We know that that's a real challenge to us, so significant financial challenges, as well as obviously the settlement of pay disputes and industrial action. So we hope that once we've done that, we can move on and make real difference again. We've still got to save money this year, and that's against, as I said, significant costs of inflation, industrial action. But we're still working, both as a system, as an organisation, to move us forward, to keep down our management fees, continue to improve our administration of everything we do, and move us forward. So that's really where we're at today. And on that note, I shall leave it with Rich.
Good evening, everyone. So first of all, I'm not very good at standing still, so I'm really going to have to stop myself from pacing. Right, let's go. So I stand here today and I represent not only the 300 staff of the ICB, but the 70,000 people who work across this health and care system to deliver some of the stuff that I'm going to talk to you about. And that covers all sorts of organisations that we've talked about before, but also all of my voluntary sector partners and all of the people who do daily work that we don't even know about to support the people that we serve. I'm going to pick out some bits which we're really proud of, but recognising, as Pauline said, Lord Darcy's report was very clear that we've got a lot of work to do to make the NHS fit for how we want it to be, for how we want it to be for our families and for those people that we serve out there. So we've got plenty of work to do, but we are on the journey to start that, and I'm going to talk to you about some of those things today. So by and far, the biggest thing that we get from an integrated care board perspective is access to general practice. So we've done an inordinate amount of work with both our general practices and our citizens at each place and each neighbourhood, as Caroline referred to earlier, to make sure that people can access their services. And if they can't, we understand why they can't access their services, and we do something about it where we can. So we've done some really positive things with things like the NHS app, which we know everybody cannot use. But actually, when we've gone out and we've spoken to people about, let us help you figure out how to use that app, actually it's been transformative for people because they're not on the phone at 8 o'clock in the morning every day waiting for a phone call. But you can see here we've opened up multiple channels of various different services based on patient need. So our general practices have been telling us for years that we've got lots of people in our surgeries who actually could be better served and faster served in other places like community pharmacy. So the community pharmacy referral service, which we launched, also known as Pharmacy First, we see about 6,000 people now in that service, and those people are what we call closed episodes of care. So they're not paid people who are then bouncing around into their general practice. They are seen, they are treated, they are diagnosed, and they go off with what they need. But what that means is that I've got 6,000 extra spaces in general practice then for those people who need it. So incremental change is how we are going to make this better for people, because we recognise it's not right as it is, and we've got plenty of work to make it right. But you can see there's 7,455,235 appointments. We had to look that number up, but it's growing every week and every month. That number is growing, and it's really important. These are not just general practice appointments, they are appointments across the whole of the practice staff, because we've invested an enormous amount of money to make sure that we've got the right staff in those services who can serve our population. The other thing I want to talk to you about is on the other side there, where we've got the integrated chronic kidney service. Now this is, you're here, you've got hospital services, you've got general practice services, you've got community services, and never do they ever talk to each other, is what we hear, particularly when we read our Health Watch reports or we listen to our patient groups. Actually, what we've done with the kidney service is join all of that up. So people are no longer having to go necessarily to a renal clinic through whichever one of my Leicester Hospital sites we're talking about, but they're getting the service in their general practice, and the results that we've got actually are outstanding from a patient experience perspective, but also a staff experience perspective, because those people are delivering the service that they think that they come to work every day to deliver. Another thing I'll touch on is the launch of our women's hubs. So we've heard time and time again that women, particularly when we talk to, again, through our Health Watch reports, our equity reports, or any other reports that we get from our citizens, that it's women's health that at the moment is suffering through long periods of neglect in all sorts of services. Bringing these services together for women, we know, has been really, really transformative, not only, again, for the women who are going through that, but for the people who are providing that service, because suddenly they're providing the full range of services for the women that we serve, rather than the individual bits that they were serving before. So really positive. From a maternity perspective, we know we've got plenty of work to do here to make maternity services fit, working with our Leicester hospitals, but also working with our community midwives and our general practices. We've got a really strong focus, particularly with Leicester hospitals, through our local maternity services, to really go out and talk to women, find out what they want, find out what actually their experiences actually are, and then doing something about it. Lots of engagement with groups that we have never spoken to before, which is, again, a step in the right direction, but we recognise a whole lot more to do there. Now, one area that we've really seen some really positive improvement is mental health. So we've launched this year 25 neighbourhood health and wellbeing cafes that focus on mental health. And when we launched them in partnership with our voluntary sector particularly, we thought we'd get a lot of people coming forward with mental health issues that needed to be dealt with. Actually, what people are coming forward with is a whole range of issues across health and care. And what we're seeing is that those cafes have become pivotal in helping us to direct our people to the right place, to the right time, before they get to a crisis. So we are sort of just in the first launch, when we first launched them, nearly 40,000 contacts we had in the first quarter that they were launched. So really popular, but most importantly, not delivered by the NHS, delivered in partnership with our community partners, some of whom I can see here today. And we're really proud of that work and proud of the outcomes that we're getting there as well. Other things that we are looking to do more of, as you'll see, is particularly for young people and their mental health. You'll have seen lots of reports about the negativity around young people's mental health at the moment. What young people are telling us is actually we don't want to go to a stuffy NHS building and get our service in the traditional way it's delivered. We want online services, but we want face-to-face services when we need them. So we've launched a whole heap of digital services, which the children and young people's feedback that we've had has been phenomenal. And we are absolutely sure from an outcomes perspective, when we're looking at what's happened to those children, that those children are getting the service that they need first time. And what that then means is that they're not having to go to more services that are focused for more acute people. So really, really sensible things, but again, wholly driven by the children and young people across Leicester City, Leicester County and Rutland. And then finally, almost our worst named service possibly, you'll see here it's called PTCDA. It's called officially the Pre-Transfer Clinical Decision Assessment Service. I did not name it. This service has been transformative for our patients, particularly who are frail. So, and I don't mean frail in terms of age, I mean frail in terms of need. So traditionally what would have happened is that these patients would have phoned 999 or 111, they would have been put into the ambulance queue, picked up at by an ambulance and then transferred to hospital. What this service is doing is making sure that those people who don't need to have an acute service but need some form of help, usually with a geriatrician from my Leicester Hospitals colleagues and a GP and my ambulance paramedic colleagues and also my DHU colleagues who I see here somewhere, Derbyshire Health United, who provide some of our face-to-face triage. What they do is they talk to each other, they figure out what is right for that person with the person and their carer or their family, and they provide the service wherever that patient calls home. Now, it's really important for that service, and if you look at the quality measures, if you look at the patient-reported outcome measures, you look at the staff satisfaction, it is really up there in terms of actually we should do more of this so we can support both Leicester hospitals and make sure our patients are in the right place at the right time. One of the biggest things from this service that we hadn't quite realised was the amount of satisfaction that our staff would talk to us about. So particularly the GPs who are working in this service, they report that they feel finally like they're doing what they need to do, which is looking after that most vulnerable cohort in the place that they want to be looked after. And if patients have to be transferred to hospital, then they are. But actually, this is the type of service we need to grow more of. I think, as Pauline said, moving that care closer to home and in the community, because that's certainly through all of our Health Watch reports and our insights is what our patients are telling us to do when it's safe to do so. A few things on urgent emergency care and on elective care. Now, you know we picked up, when we formed as an ICB, urgent emergency care continues to be one of our most challenged areas. We know that the waits that our patients have, both on an elective care and an urgent emergency care perspective, are not where we want them to be. That said, we are the fastest improving system, particularly in Leicester hospitals, for elective care and our cancer care, particularly for the faster diagnosis standard, which means that you get seen and diagnosed for cancer faster than you would traditionally, up in almost the national top quartiles as the fastest improving services in the country, all down to all the work across our Leicester hospital services and our general practices. For urgent emergency care, we know we are challenged, we know we've got a lot to do to improve those pathways, but as I said earlier, in all the examples that I've just given, the more we shift the care to the community and care in where people want to receive it so they can access care earlier, the less impact we will see, particularly in our emergency department and our ambulance services. We are working together as a partnership on all of that to make sure that we are looking at the whole pathway and not individual parts of the pathway as we previously have done so, but plenty more work to do there. And then finally, just Caroline's talked about place. So this is where we work with our 3 places in particular. We've just got some highlights from each place. So you can see there from a city perspective, we are up in the high 65% for dementia diagnosis rates. And the reason we pull that out is because traditionally City had been one of the lowest places in the country. We've had some really good partnership working across the general practices and our Leicestershire Partnership Trust services, and we've pulled that up all the way to 66%. You'll see here as well some of these things which are really hard to shift. These are improvements in public health long-term benchmarking, where we have always been red as a city. We have finally moved those to amber through the work of those 70,000 people that I've referred to earlier, but in some really important areas. So you can see their mortality rate for cancer, smoking status at time of delivery, which we know is really important for the children and their development, and then also things like alcohol-related admissions, all because of the work that we do in partnership with our communities. In county, we've got some very specific examples here, but particularly in places like Charnwood, in places like North West Leicestershire, in places like Oadby and Wigston, we are seeing a real shift to neighbourhood delivery, and we're seeing a real shift to making sure that services are delivered in the places that we find people. So if I look at Oadby and Wigston, for example, the mental health cafe in Oadby and Wigston is slap bang in the middle of Wigston High Street. You wouldn't have seen that before. This is the stuff that we've been learning about, how people want to access services, where they want to access services, and then going out and finding somewhere which is suitable. And then finally, Rutland. I will talk about the social prescribing here in particular. So Rutland have got a partnership between their primary care networks and Rutland County Council and all of the parish groups that we've got in Rutland. They've created an entire network of social prescribing, which is effectively the community helping each other with some supported work through something called the Joy platform, which if you haven't seen, please go and have a look at the Joy website. It's very good. It tells you where all the services are in your local area. But what that's doing for Rutland is making sure that our people in Rutland know where their services are, they know where to get help, and more importantly, they're helping each other as and when they need to, particularly at parish levels, not even neighbourhood level or place level, but at parish level, which is really, really great for those services themselves. So I could go on forever, but I think my time is up. So I'm going to hand back over to Caroline.
Thanks, Rach. I've got 1 minute to talk about the future. So I think the thing for the future is, Robert's talked about our financial challenges. We've got to get back into financial balance. The only way to do that is to really think about delivering care where it's most cost effective and making sure that we are really productive in the care that we deliver. And it's through this partnership approach that, and that we think we can transform services to be able to do that. Transforming services that focus on the right things for patients in terms of equity and improving outcomes, and making sure that we've got ease of access. So all of the things that Rach has been talking about over the last few slides are the things that we want to build on, and we want to have more examples of that working. The Darcy review is really critical for us. It tells us the things, as Pauline says, it tells us things that we know that are wrong with the NHS, but we also know therefore what we need to do to make it right. And the specific role of the ICB in that is convening the system to deliver the best for its population, and that's where we're going to focus our efforts. We know that our hospitals are excellent at what they do. They've got their challenges, we need to support them, but we also know that by working in partnership we're going to deliver better outcomes, and so that's where we need to put our focus and our energy to deliver more on. So Pauline, I'm going to hand back to you.
Okay, so the first question is a question from colleagues in the Jamila legacy. And the question is, we know that there is an increase in demand for mental health services locally. What are ICB's future plans in meeting these needs? I'm going to ask Caroline if she'd answer that, please.
Yeah, thanks for that. Thanks for the question. I think Rach's presentation demonstrated the things that we are already doing for mental health. And I think it is more about how we can focus on that prevention aspect of it, to get earlier on in the pathway, to really think about whether it be adults and children or young people, to make sure that we've got those services in place. Because we know the specialist services are really challenged. So the more that we can do to tip it into early identification, early prevention. And I think one of the things that we really need to think about working with our local authority colleagues is where they can join us as well with that. Our mental health pathway, our collaborative around mental health, is one of our most successful ones, because we work really closely with our mental health and voluntary sector colleagues on that. And I think the thing is we want to do more. Robert will say from a finance perspective, we've got the mental health investment standard, and so that's really we're required to demonstrate where we put additional investment into mental health services, and year on year we see that increase. Absolutely a really important part, but hopefully you've seen some of the stuff that we are doing that we're building on.
Similar question from our colleagues in the Jamila legacy, and really what they're asking is, how are we planning to address the health inequalities that exist in LLR, and will this be different to our existing approach? And again, I'd ask Caroline, or is it Rach? Rach?
Oh no.
We will do a double act between Neil and myself. So our entire focus of what we've just talked about is to make sure that we can have three things. We've got two on the board there: equity of access, equity of outcome and equity of experience. And if we haven't got those three things, then we're doing the wrong, focusing on the wrong things. So our approach to health inequalities as it stands at the moment has been to take a population health management approach, which effectively means taking all of the data that we've already got looking backwards, projecting that looking forwards, and then spending the money on the right things to help those people who we know will need help. That does mean that we need some real data intelligence and business intelligence, but we also need to work with our communities, because actually the reason we've got so much inequity that we have built into all these pathways is because we've expected people to come necessarily to the NHS type services, when actually we know that that's not going to get us equity, it's not going to help us with inequality, and it's not going to help us get the outcomes that we want for those people that we serve. So it is about changing our mindset, it's about changing the way that we work, as Rahana said, and really working with our communities to understand how we get the best for our people by working with our people. Neil, did you want to?
Yeah, hi, I'm Nelson Gardner, the Chief Medical Officer of the ICB. Pleased to be here. Thank you for coming. We've got a really strong focus on health inequalities. It's our most significant risk as an organisation, as a system. It's our first pledge. You saw the pledges in there. We want to make all our services really equitable, as Raj said. So there's a few structural things. So we have a Health Inequalities Committee, which makes sure that we invest in health inequalities. So this year we were only a few systems actually that decided to ensure we spent every single pound of our health inequalities funding, and we put that to general practice to make sure, as Raj said, that where the need is greatest, we were funding those services locally. So whether it's mental health, whether it's access to your nurses or GPs, all of that, we ensure that those GP practices that have got real need in their areas and their communities and have the right resource to do that. We also have some other things that we do to make sure we're prioritising our investment. So whenever we think about a new service, a new business case that we want to invest in, we have a focus so that 30% of the whole decision focuses on health inequalities. So it's really fundamental to what we do. But actually, one of the best ways of dealing with health inequalities is that community approach. So making decisions as close to the patient as you possibly can. As we've all said, often it comes down to access. And the people who know how hard it is to get access are the patients, are the public, are our families and our carers. And listening to what they say, and putting services around them is the best way to do that. So when we think about vaccination, for example, we have a bus that we can go out into hard-to-reach communities to make sure we're delivering those vaccinations in a workplace or in a church dwelling or mosque, wherever it might be, to access those populations. All of our general practices have a particular focus through primary care networks on a particular different area that's important for their community. So it's really fundamental to what we do. But we also know that health inequalities is not just us in the health service. 80% of your health is about stuff that's nothing to do with the health service. It's about your housing, your accommodation, your education, all those things that we call the social determinants. So working with our local authorities, working with our social care sector and our social prescribers in the voluntary sector means that we can help people who might come to us because what was a mental health problem, but actually they're struggling to get to work, they're struggling to look after their family, they've got financial problems, they may have drug addiction problems, and so community services are really important. So we're embedding it into everything that we do. And we've said earlier on, we've got a really diverse population. Leicester City is the most plural city in the whole country, so we've got a really broad ethnic population. We've got significant levels of deprivation, so we have to continue work on that to embed it in all that we do.
Thanks, Neil. Okay, over to you again then. Anybody?
I was a former board member of the CCG up until recently, up until the last couple of years. At the beginning of this year, I spent a couple of weeks going into the A&E department, looking at the numbers of ambulances, talking to patients, speaking to them. I've been to the urgent care centres, and one of the real big worries and the failures of Leicester is that we've never ever been able to deal with the problem of patients not getting beds at the hospitals. Even today, I've walked past 16 ambulances waiting at the A&E department with patients in them. I was on holiday twice during this year. Both times I had a phone call from a resident. In one case, I was in Saudi Arabia and had a resident call me and said, I've got my 80-year-old mum who's in the kitchen. It's 8 o'clock at night here, and we rang the ambulance. They said it's going to be 11 hours before they get to us. The second occasion was I was on holiday a few weeks ago, and I had a phone call, and it was a 6-hour wait for a heart patient to get in, to get the ambulance. And I know the system just doesn't work. We have 2 urgent care centres, but no walk-in centre. The walk-in centres don't take walk-in patients anymore. If you ring 111, which is what everybody is directed to do, you dial 111, and lots of people come back to me and say, oh, they call us back 6 hours or 8 hours later, and by then they've already gone to A&E. And next time they won't ring 111, they'll just go to A&E, because that makes sense to them. They're not going to hang around. So why is the system continuously failing the public in Leicester and Leicestershire? And there's still a 10-year gap life expectancy in Leicester City in comparison to the county, and that is huge.
Yeah, thanks for that. And I think everybody knows that up and down the country, urgent emergency care services is still really difficult to manage. We are no different to most systems. We still have struggles in that area. Our hospitals work incredibly hard, and as you said, you visited the A&E department, and they try their best to get the patients through as quickly as possible. Our ambulance service, Eastman Ambulance Service, is phenomenal. We have one of the lowest conveyance rates, which means when you call an ambulance, actually in our area, you're less likely to be conveyed to hospital than many other areas, because our ambulance service is doing a great job to make sure that it can see and treat. So when it gets out there, they're trying to see patients in the community and treat them where they possibly can without having to send them in. We have a range of different services. It's a complicated system, which makes it hard for patients as well. We've got different urgent care centres across the area, the geography. We've got access to general practice, we've got pharmacy first, which is all part of that as well. What we're really trying to do, we're working really hard to do this, is to make sure that if you do need to go to A&E or to the hospital, wherever possible, we can try and get you into the service that you need. So rather than having to wait in a very busy A&E department for many hours, if you've got chest pain, you can go straight to the cardiac unit to be seen and treated quickly. And this is something that we call same-day emergency care. So you can try and get the diagnostic tests, see the specialist that you need to see, and you turn around really quickly and get back home. We know that's great for patients, and it means that we're not using our beds for patients who don't need to be there. But it's still a challenge, and we're still trying to work on that. We've had some real successes, though. So whilst we still do have our challenges, we categorise our emergency patients into category 1, 2, 3, 4, and 5. And the category 1 and 2 are the ones that you're talking about, the patients who may have had a road traffic accident or a stroke or a heart attack, and absolutely they need an ambulance. But we know that category 3 and category 4 patients, many of those don't necessarily need to be treated in hospital. And what we want to get to is getting our community services to manage those patients really quickly. So with Derbyshire Health United, I've seen colleagues in the room today, and with our community nursing teams and our wider community, this is this integrated way of working, we're trying to get a response to those individuals out in the community. Take a patient, an elderly patient who may fall at home, who may have not broken anything, may not be in hospital for several days at a time. We're taking that call from the ambulance service and saying, actually, can we get our urgent care services out to you in the community, and wrap care around you and keep you at home. We've got a lot more to do. We still have ambulance waits. It's still very challenging. We're doing that as much as we possibly can. We're trying to streamline those services and get the patients to the right place at the right time. Also want to comment on our social care colleagues who are working really hard at the other end when it comes to getting out of hospital to get patients in really quickly. And again, we've had some massive improvements in that area. So if you need a care package now, we're getting those care packages really quickly, and we're turning patients around really quickly. Our hospital flow is also improving. But we recognise we've got a lot to do. We're a system that's struggled with this for some time. And we've got a new structure now that we're trying to implement to make sure we have a really concerted focus on this. And this is a great example, actually, of partnership working from healthcare to social care and doing the right thing for all our patients. So more to do, but we're working very hard on it.
Thanks, Neil. I'm going to move back to the written questions to make sure that we get through them all. And the next question is from Ian Crosby from LLR Mind. And it's a question about keep it local. And it's a question asking the ICB, will we commit to West Yorkshire's ICB example of keeping it local? And I'm going to ask Ratch to respond to that, please.
Thank you. So for those of you who don't know, Keep It Local is a set of 6 principles, effectively, which does really what I talked about earlier. If you've got a place, or you've got a system, or you've got a neighbourhood, how do you work with that community, in that community, to provide the best services? So whilst we haven't signed up to the formal pledge, we absolutely, I hope you've seen today, through some of the examples that we've given and Rahana's input, but that's exactly how we work. That said, we have got an Alliance Day in, I think it's a couple of weeks' time, where we are quite happy to have a look at those 6 principles and assess ourselves against that. So we haven't formally adopted them, but that's just the way that we've always worked. So we will, that's our commitment, that we will look at it and we will absolutely make sure that we're signing up to it. We will communicate that with our partners. I will say though, the question came from Ian from LLR Mind. The work that we do up in North West Leicestershire with Ian and colleagues shows the power of that partnership working. The work that we do in the city with our city groups shows the power of that partnership working and actually evidences whatever I put on a piece of paper. Actually, we're living it and breathing it, and if we can do better, we absolutely will.
Thank you very much, Rach. Actually, I'm going to take the next question because it's a question from Marla Shah Baruda Shah. And the question is, since COVID, there are virtual ICB meetings that members of the public can attend. However, not everyone can access the meetings virtually. The virtual meetings create a barrier between the board and the public. It would be preferable for public meetings to be held face-to-face to allow all members of the public to attend. Will the ICB hold future meetings face-to-face or not? Well, I must say I have some sympathy with this question, and it's something that we have talked about as a group of NEDs in particular. And we've got to be really careful when we move to digital that we don't exclude people, and running all our board meetings digitally through Microsoft Teams actually does exclude some people that are not digitally active. So my commitment is that when the new chairman joins the ICB board, which hopefully won't be too long, and I hand over the reins to the new chairman, this is one of the issues that I want an early conversation with, and ask the new chairman to consider about how we hold board meetings in public going forward.
We spend most of our time at our board meetings discussing where it doesn't go well, and I think that is where where our focus has definitely got to be. The successes, we bring one successful story into our board meeting, whether it's a patient story or a staff story, because it's important to reflect where it is going well, because the NHS does spend a lot of time focusing on where it isn't doing well. And I was at the UHL board earlier this week with you. You were there. Richard was talking about where they've still got a lot to do. We still talk about where we've got a lot to do. The Darcy report talks about the fact that the NHS is broken, but the vital signs are still there. And if we don't focus on the vital signs and the positives that we're doing, we'll start to disengage people. And I think that's a danger if we don't get the balance right. But absolutely, we are not living in cloud cookie land to think that we have got everything right. We've definitely got loads of stuff to do. We've got a huge financial challenge, we've got a huge challenge around urgent emergency care, and this is where our collective efforts are focusing on how can we do something different. Accountability is an interesting one because we are held to account, aren't we? The Health Overview and Scrutiny Committees, I think, have taken place this month, where Duffy, you're there, you're having to hold us to account in a way that sometimes feels a bit uncomfortable, very uncomfortable. But our local politicians hold us to account, and our population hold us to account as well. We're absolutely accountable to our population, and we do that through the Health Overview and Scrutiny Committees. Part of that accountability has got to be the second bit we're talking about engagement, and making sure that we do engage with the population on a wide basis. And I think the engagement events that we do, being out here in public, where we want to see people, we want to see them face to face, we don't want to shy away from challenging comments and challenging questions are really important. But also the work that we're doing through the Voluntary Care Sector Alliance, going out to engage with our partners in that space, and then the myriads of work that we do to engage with individuals and communities. And I'm going to do a little bit of a plug because on the 9th of October we've got a Children and Young People event where we're absolutely doing that. We're listening to the voices of children and young people in LLR to understand what it feels like to be cared for by the system in LLR. But again, we need to do more. We need to take every opportunity. And Tony, the work that you've challenged us on in terms of how we engage with carers is another critical piece of work that we're doing. We haven't finished that piece of work. We need to make sure that we're testing it. Are we doing it appropriately? And then getting this kind of feedback is part and parcel of that engagement piece of work.
Thank you very much, Caroline. And there is quite a long question here that we've received from Shilpa Arya, which actually, much of which Caroline has just covered, and Tony picked up in his question. But there's one particular part of the question I think it's worth reading out and having another go at answering, Caroline. And that is that when West Streeting talks about reform in terms of greater use of AI, providing services in the community that are closer to home and are focused on prevention, what does that mean for family carers who are already under undue pressure and strain from their caring roles?
Yeah, so I think it puts more pressure on family carers, and we've got to recognise that. We think about, we've had a board discussion 2 board meetings ago where a member of the public was talking about how he is supported to use his cardiac monitoring at home. And that's great until it goes wrong, until he needs somebody to speak to, and somebody needs to be there to interpret what's going on. And so those examples, learning from where it's happening now and thinking about how if we're going to increase it, if we're going to expand it, that's the engagement with the carers that we need. So it doesn't feel that it's done to them, but that we're taking people with us on that journey and understanding the impact and trying to put some mitigation around it right from the start. There's nothing worse than trying to retrofit it for carers because we haven't engaged with them properly. And so I think that's our commitment to carers. The more we're doing in the community, the more that we're working, the less that we've got reliance on those big acute hospitals, the more we're doing to keep people well in the community. We've absolutely got to understand the impact that it's going to have on people.
Thank you very much, Caroline. I'll take one last question.
Hello, my name is Jane Hurst, so I work for the National Centre for Creative Health. So we look at how the creative and cultural industries can support the health service to reach their goals. In Leicester, Leicestershire and Rutland, I can see where public health is able to start integrating those things. So I guess my question is, in the presence of more vigorous evidence that shows where we can help by creative interventions, is the ICB receptive to looking at that kind of creative approach to health?
Yeah, and I had the opportunity to catch you earlier before the meeting, so I think it's really important. You'll have heard us talk about well-being, and there's this interface between ill health and well-being. Actually, sometimes it's your well-being that's not great. So you may not have mental health issues, but your mental well-being may not be great. We talk again about that 80% of health that doesn't occur due to NHS. And the reason we talk about our partners so much is because we know that our partners really help us with keeping people healthy. So that's so important for us. So, for example, exercise programs. You were talking about dance classes for the elderly, Tai Chi that can actually help with falls. So we have a really high admission rate in our fair elderly population through simple falls. It's because perhaps they've lost some muscle strength and they're more likely to fall. And we know that things like dance and Tai Chi, as well as being actually helping with things like loneliness, we know we've got significant issues with well-being because of loneliness, can help with their fitness. We also know there's a whole raft of things in terms of art therapy, which again you were talking about, that can help children with mental health problems express themselves. We've got a really, really long waiting time for neurodevelopmental assessments, so that's ADHD and autism. There's a massive array of things that can be done outside the health service in terms of creative stuff. So the answer is absolutely yes, and we want to do more. And one point I want to make in terms of the financial situation is that we've still committed really quite strongly to investing in the voluntary and community sector, because we know that in terms of productivity and efficiency, we get a really good bang for our buck there. We get enormous output from our voluntary community sector. We know there's a whole range of charities that absolutely help our patients on a day-to-day basis, and through our social prescribing and other colleagues, and we can refer our patients to those, and they get great resource and benefit from that. So again, it's not all about what the health services can do, it's about what we can do together with our partners. So yes.
Thank you very much, Neil. Well, that brings today's or this evening's meeting to a close, and the end of our annual report and annual
General meeting.
Annual general meeting. Thank you, Caroline. I lost the words there. I think you've heard today about some of the successes that we've had, and we're happy to share with you, but also some of the ongoing challenges that we face. Urgent and emergency care not being the least of them, and also financial challenges going forward. So it's going to be an exciting year, a challenging year, and a very busy year. But we're all up for it. Everybody in the ICB is committed to wanting to make things better for our populations, and I give you our commitment that we're all giving it 110% and will continue to do so. So thank you very much again for coming out on such a horrible evening with the thunder and the lightning and the rain, and I wish you a safe journey home. Thank you very much.